we're at the top of the hour, and we've actually got a lot to cover today. I am Nora O'Brien. I am the CEO of Connect Consulting Services. I just want to say thank you very much for joining us today. We're going to be talking about the CMS Emergency Preparedness Rule. Changes since 2017, like as I said, a look back and a look ahead. There have been quite a few changes. I mean, for many of you that follow federal regulation, generally I haven't seen this many changes in such a short amount of time. So, and I'm sure you want to both be prepared for disasters, but also stay on top of what those rule changes are. So let's get into today's presentation. Let's see here. All right, great. So today, again, this is a little bit about me, but also our organization, Connect Consulting Services. So emergency management and business continuity planning expert. I launched Connect Consulting Services in 2009. What we have been blessed to do is assist clients across the country with developing emergency management and business continuity plans, done tons of training, drills, and exercises. We added it up recently. We've done well over 200 tabletop exercises, full-scale exercises, trainings on CMS. So we're kind of all in a one-stop shop where it comes for CMS compliance. My background is I have a master's degree in public affairs with a concentration of disaster and emergency management, certified emergency manager for International Association of Emergency Managers, also served for the Healthcare Caucus Chair for IAEM. I'm a FEMA instructor in my spare time with air quotes. And Connect Consulting Services was named Women-Owned Business of the Year by Sacramento SBA. So we were very blessed to have that designation. So moving on to our next slide and kind of getting into the meat of things. So what today, and again, a little bit about what we do. Our goals are really two things, and hopefully this will help your organization as you look to meet, exceed the CMS compliance. We want to create safer disaster resilience organizations. So we want to help you meet those CMS. We or anyone else should want to be able to have you meet those CMS emergency preparedness compliance requirements, which is a mouthful. But more importantly, we want to make sure that you're disaster resilient. And how we do that is through emergency management and business continuity training, planning, and exercise programs. That's what our vision is, and hopefully that will help your organization as well. Okay, whoops, we went pretty fast there. Sorry, it's like, wow, that's a quick presentation. So today our agenda is that we're going to be talking about the requirements. Now you probably, everyone that's on the call, and actually we have quite a few of you, maybe are experts already in the emergency preparedness compliance requirements. So we're going to talk about that and touch on those briefly. Then we're going to talk about what those rule changes mean. There's actually a rule change from this year, as also the ones that are coming up that go into effect November 29th. And then we're going to talk about how many CMS providers are faring on meeting their requirements and passing their surveys, and also provide you some compliance strategies that you may have not thought of. And we also want to hear from you. Actually, we didn't include that, and we left a fair amount of ample time for having you share with us your compliance challenges and success stories and strategies so that we can share and learn from each other. So who is on today's webinar? So I do want to say that, and these are many of the providers we already work with: hospitals, home health, hospice, skilled nursing facilities, community health centers, dialysis, ambulatory surgical centers, but we also have healthcare coalitions, public health agencies, provider associations. That's who's on this webinar today. And so the point is that we are not going to be getting super deep into the weeds of each of the provider types and what your requirements are, because they're now a little bit different, but we are going to give you a general overview. If you have questions, or if you'd like us to provide this webinar to you, to your provider association on a national, state, or regional level, we're happy to do that, or your healthcare coalition. Just let us know so we can, and then get more. And we have done that significantly for a lot of our clients and partners. So happy to do that. So this is an idea who's on the call today. So although you're happy to ask us questions about your provider type specific questions, we're kind of giving a more high level overview. Okay, so just in the very beginnings of this is, why do you want to prepare? And really what CMS was looking for when they developed the compliance requirements. And they actually came out, there was a proposed rule, as you know, with most federal regulations, they propose them, they get feedback, and then they finalize them or not. And the proposed rule, which actually came out in 2013, and what their intent was, is to standardize across the emergency preparedness practices across the continuum of care. So those best practices, whether it's hospitals or skilled nursing or community health centers, that they're across the continuum of care, there is a standard emergency preparedness compliance. The intent is, it's also built on best practices of emergency management and business continuity, so that it's, again, not just, hey, by the way, this is additional paperwork that CMS wants to, just have you fill out more and do more drills that really have no meaning behind them. They really are built on best practices. The other thing is, it's really important that you, serving the providers, the patients that you do, patients or clients or residents or participants, your constituency, you all know they're vulnerable, and they are very vulnerable communities in disaster, whether you're on dialysis, you're in a skilled nursing facility, you're a community health center that has very limited resources and maybe can't evacuate when those notices of evacuation orders go out. It's just important. So those vulnerable populations in disaster, CMS was looking for better health outcomes for those patients in disaster. And then also allows you to proactively plan and train exercise for all types of disasters, because it's not just cyber breach, it's not just flood and fire, it can be it's on all hazards event. So touching briefly on what the compliance requirements are, in 2017, CMS said that everyone there's 4 core requirements for all provider types. One is to conduct a risk assessment and develop a plan based on those risks. And the important thing about that is that what a lot of people were doing was developing a plan, and the risk that they wanted you to conduct is not just the risk to your community. Like, you already know, like, we're based in Sacramento, we already know we need a flood plan. We have the highest flood risk in the nation. But we also have fire. We actually had fires this last week, and so that's also a risk. So what's the risk to my community? But the other thing that they wanted you to know about is, what's the risk to your facility? And it could be you're right next to a bus station, or you're very close to a chemical plant that could be a release of some kind of hazardous chemical that might impact your patients and your families and your staff. So identifying a risk, doing a risk assessment and developing a plan to address those risks is what they're looking for. Then they wanted you to develop policies and procedures, and those policies and procedures are really aimed at effective response and recovery. The important thing about it is that whether it's evacuation or coordination with other facilities or patient tracking, those policies and procedures is really where that they really looked at how you can best recover from disaster. In addition, communications plans, because we know in every single disaster, it doesn't matter, communications always goes down. Everyone seems to think that group texting is the thing, or satellite phones is the thing, or cell phones are the thing. But by creating a communications plan about what's going to work best for your jurisdiction and for your organization is what CMS was looking for with that requirement. And lastly, the training and testing. So that's the best practice that we see, that if you are testing your plan in advance of disaster, your organization has muscle memory. Your staff know what to do and what the procedures are and who to call and those kinds of things. And you also train your staff on those procedures, and then you test it and say, our evacuation plan is to evacuate out of these 2 exits, but we did a drill and we realized that we need an additional assembly point or whatever those things are. But those training and plan testing is you hypothesize of how to apply your plan, and it has to be drilled because you have to give that staff your muscle memory, but also you want to update the plan based on on your findings. Your organization might change, and so that's why that plan testing is really key. Okay. Here we go. So CMS had 17 provider types that were impacted by this rule. As you can see, this is a very long list. And really, again, it's across the healthcare delivery spectrum of, again, from hospitals, from the highest acute care to the outpatient setting. Everyone needs to be better prepared for disasters. That was the intent. And so now we're going to get into the rule change and sort of what's been changed since 2017. So even before the rule went into effect in November of 2017, CMS, because they came out with the rule and actually in 2016 and said everyone has till November 15, 2017 to have their plans in place. In June of 2017, we actually got some clarification. They did an interpretive guidance to clarify what they meant by full-scale exercise. Now, we're a longtime emergency management firm, and we understand when you say full exercise to us, we think, and maybe many of you do too, lights, sirens, blowing stuff up, 50 fake patients, blood and impalements, triage tents set up everywhere. And that's when you think full-scale exercise, because you are really exercising every bit of your plan. What we found out in 2017 is what CMS, what they meant by full-scale exercise was an operations-based exercise. So you're testing a piece of your plan that is operationally and not just doing a tabletop or discussion-based exercise. You are figuring out whether it's your communications or evacuation or your incident command or whatever those things that you exercise, they meant clarify what that full-scale exercise requirement meant. So in 2017, what they also did is made available, and this is the link, and I believe they put it on the resource page as well. If you want to know what the surveyor training, what the surveyors, before they come to your facility, what they're trained on, you can go to that link, and I'm sure they will or have already updated that training for these new requirements. So that's a link to keep in mind. So on November 15, 2017, all CMS providers and suppliers had to meet those 4 requirements that we shared with you on the previous slide. And in September of 2018, the proposed rules that just got finalized, they came out and said, hey, by the way, what do you guys think of us reducing and relieving some of these burdens in their view for the rule? And so people provided public comment. Many of you on the call might have done as well as we did. And in February of 2019, CMS providers now have to add infectious disease to your emergency operations plan. You also have to have score it in your hazard vulnerability analysis or HVA that we talk about. And also in the past, one of the requirements was that if you've had an activation of your emergency plan for a real event, and it could have been a power outage for a short time, or it could have been a hurricane, flood, earthquake, etc., you actually could allow one of those exercises to be one of those events count towards your full-scale exercise requirement for up to a year. And in February 2019, they confirmed that actually, since there were 2 exercise requirements, if you've actually had 2 activations, actually that can also count towards both of your exercise requirements. So those are some of the updates that came out recently. Okay, now we're going to get a little bit more into detail. That's probably why most of you have joined us today. Talk about the newest CMS Emergency Preparedness Rule. This goes into effect November 29th. So it's the Omnibus Burden Reduction, Conditions of Participation. The hot link there goes directly to the information. So if you want to read all 75 pages of that document, have at it. Go right ahead. And what we've tried to do today is kind of distill what the highlights are of the rule change. And if you have further questions, please share with us today, ask those questions on the call, and or reach out to us and see if, or your provider association to see what those, how we can, how to get those questions answered. So one of the big things that that was a rule change was removing the requirement from the emergency preparedness rule that you have to contact and document your local, state, tribal, regional, and federal emergency preparedness official coordination. That's something that I have to say I have a little bit of heartburn about, because that's something in my view kind of made the rule a good thing so that you know your partners in advance of disaster because it's a best practice. So that was one thing that it removed. But although it was a removal of a requirement, we think it's a best practice. So we recommend to our clients that you keep those efforts in play and you keep planning and exercising with them just because it's so important, because that's what helps keep your organization and your community more resilient. The other thing that another piece of it is that you have to now review your emergency plans every other year instead of annually. Now, long-term care, because of the vulnerable populations that you serve, you now, that doesn't apply to long-term care. So ICFs and skilled nursing facilities, you'll now still have to review your emergency plans every year to see what might need to be changed. On the training side, you know, the requirement was that you train your staff every year on your emergency procedures previously, and then also at the time you hire people, so your initial, and then you document them when you've done that training on what your emergency procedures are. Now another rule change going into effect November 29th is that you train your staff annually, in every 2 years instead of annually. Again, we think it's a best practice. I think there's no downside to actually doing it on an annual basis. It's going to be harder, I think, to track if it's, do we do it every 2 years, every year? Just, it's easier just to schedule something every year. The other big change is reducing the testing requirement from 2 exercises to 1 for outpatient providers. So if you're an inpatient provider, you still have to do 2 exercises, but you have a choice. You can do a functional exercise, a tabletop exercise. You still have to do those 2 exercises, or you can do a full-scale exercise. So you've got some latitude of what's going to work best for your organization. So those are the big changes. Do we have questions? No, not yet. Okay. Well, if you do have questions, what we encourage you to do is, as we go through this presentation, if you have questions, put them in the question box, even if, like, you know, we're going to get to them at the end and answer those questions, if that way you don't forget about it. We do want to hear from you and see what those questions are, because the question or comment you may have may help somebody else as well. So
we do have a question.
Yes.
Regarding the testing requirement, is a home health agency considered outpatient?
Yes, as far as I know. And that's a really good question. So what I can tell you is, I know home health and hospice had a number of changes. I believe so. But what I do want to tell you is, again, the rule changes just came out a few weeks ago, and we are still getting a handle on what those changes are. So I'm going to say yes, but I'm going to be, we'll do the research and we can also get back to you as well. So, and at the end of this presentation, you have our email. You can reach out to us via email.
We will email you the link to the recording and the download for the slides after the call.
Yes, that was a question. Yeah, the question came out about Okay, so good question. All right, we're moving on
I
here.
have another one.
Yes.
What is the difference between training staff and testing staff?
Really good question. Thank you. So the difference between training staff is you're doing your staff. So let's say you can do a lunch and learn. Here's our emergency procedures. Here's how we would do evacuation, or this is our procedure for patient tracking, or this is, and you'd give them those procedures and just train them on that information. Testing is where you actually set up a scenario. Of a scenario that's likely going to impact your organization, like flood, fire, cyber breach, active shooter, whatever those things are. You set up a scenario, and that will test you're testing your plan of what your plan says about what to do. Do we shelter in place? Do we evacuate? Do we run, hide, fight? Do we set up a triage tent, for whatever those procedures are? And so the testing, what that does is finds out, are your plans robust enough to support that particular scenario that's impacting your organization? So like if you think, oh, well, we need a lot more detail about flood or active shooter or whatever the scenario it is, but that's what the exercise. So you can do it at a tabletop or discussion-based exercise, or you can do it as whatever the scenario itself is. When you test it, you're testing to find plan gaps and not testing whether your employees remember what your procedures are.
I'm getting a lot of questions about specific types of providers.
Okay.
And how many exercises per year for each of them.
Okay, so we'll get to that in a little bit. Yeah, we want to make sure we have enough time to get through all the slides. So don't worry, we'll get to your question. And if we can't by the end of this presentation get to all your questions, if we need to do a frequently asked questions document and send that out to you, we will be happy to do that as well. We've done that for previous presentations. Okay, so again, this is a little more information about the CMS Omnibus Burden Reduction. That's also a mouthful. So it advances their CMS's Patients Over Paperwork initiative. They think that these changes mean saving providers 4.4 million hours of time spent previously on paperwork, and they're seeing about $800 million annually. It finalizes the provisions for 3 distinct proposed rules. The regulatory provisions promote efficiency, transparency, and burden reduction, the one that I had talked about previously on the update slide that was updated last September. And then critical access and hospital changes to promote innovation, flexibility, and improvement in 2016. And then fire safety for certain dialysis facilities, published in 2016. So what it does is takes all of those things and finalizes them all into one rule. So that's it all. Now that's why it's referred to as the Omnibus Burden Reduction. So while each proposed was published separately, they finalized them in one rule. Again, to try to be efficient as possible. So here's a couple of points about the rule in 2017 versus the 2019 rule change that came in. So the difference in 2017 is that it was the same plan review, training, and exercise requirements for all 17 provider types. And the advantage to that is, again, everybody understanding the same requirements, the rules, when they have to do things, and it makes it easier if you want to do exercises with your partners, etc. Most of the variants in the emergency preparedness rule in 2017 were really in the areas of policies and procedures. So for example, if you're an inpatient provider, you had the sustenance, you had to provide a generator, you had to provide food and water and medical equipment, etc. Versus if you're an outpatient provider, you only had to do shelter in place, medical documentation, use of volunteers, and evacuation. So it just kind of where all the variants really was centered around the policies and procedures area. So the inpatient providers, had more had more requirements just because there's more requirements of serving more patients or residents, et cetera, sustenance generators, patient tracking, et cetera. So in 2019, kind of a way to think about what these rule changes mean, it changed the frequency of activities, but didn't eliminate when the providers need to review and update their plans. So that it's not just, they didn't eliminate everything, they just when you had to do it. So inpatient providers still need 2 exercises annually, but you have a flexibility in what type of exercise. I know for Joint Commission at hospitals, there was a difference in what was going to count for a CMS survey versus a Joint Commission survey, and so that was one of the issues that they looked at. Outpatient providers need to do now just 1 exercise annually. Again, we always recommend more, just because the more you test the plan, the more robust your organization, and the better you'll be prepared for disasters. And we're not saying that just because we do drills and exercises. We just think it's a best practice. You're always welcome to go above and beyond. In addition, which I talked about, eliminating the local, state, federal, tribal coordination requirement. There's also other specific provider-only requirements that are different in 2019 than there were in 2017. So we can talk about those when we get to that section. And then clarified generator requirements, because that was a lot of questions from a lot of organizations about what did you mean by alternate power, and so it clarified what those generator requirements are. So that was 2019. Okay. So here's a couple of things that we've seen in working with providers on the ETAGs, the emergency preparedness tags. So surveys are being conducted by either health surveyors or life safety code surveyors. It's going to vary by state. So that's a question we actually get a fair amount, and said, so who's going to do service? We haven't been surveyed as of yet. When are we going to get surveyed? Who's going to be doing the survey? How much notice are we going to get on the survey? So while I'd certainly love to have a crystal ball and know the answers to those, it's going to vary by state and sometimes by provider type, because some providers are surveyed at different intervals than others. Like hospitals tend to be every 3 years, skilled nursing facilities usually every 18 months. So again, it depends on your provider type. So some of the trends that we've been seeing is people not building an emergency plan based on a hazard vulnerability analysis. That's important. And because what they're saying is they're just going to build a plan, but again, that risk assessment is something they want you to do. And there's some specific requirements around the hazard vulnerability analysis or the HVA. Like, for example, if you're an inpatient provider, you have to score a missing resident. Do you have a plan for addressing a missing resident? And they want to make sure, are you prepared for that? Other kinds of trends that we've been seeing, and this is across provider types. So we've heard this from hospice, we've heard it from skilled nursing, we've heard it from home health, we've heard it from hospitals. This is the kinds of things that people are, dinged, so to speak, or getting for. People are not developing required policies and procedures. They're maybe, and again, they're different based on your provider type, but they're not developing those procedures and policies. They might have a safe evacuation and shelter in place, but maybe they don't have one for patient tracking, and that provider type requires that they do. We've also been seeing the trends where people are not establishing and coordinating with local, state, and federal emergency management officials. And again, that's now not a requirement, but that's something that people have been tagged on, people have been cited for. And so that's again, and we've seen this with a number of different provider types. The other thing is not training staff on emergency procedures. So your staff are not aware of what your shelter in place process is, or evacuation, or your evacuation routes, or assembly points when you get out of the building. You're not training your staff on those kinds of things. The other thing that we've been hearing a lot is not conducting and documenting required drills and exercises at all. People have said, well, we might have a plan, but we just don't exercise it, or we don't do it regularly, or it's just a very minimal sort of like we get out of the building in 5 minutes and it's not based on our plan. So they're getting tags for those kinds of minimal drills. And again, too, if you're doing a drill and it's over in a minute and you have no findings, and all you're doing is you're telling yourself that you can walk out of the building, it doesn't really help you because you really haven't tested much of your plan. And then lastly, not developing communications plans, because on the communications plans, so it's not just, hey, by the way, establishing, coordinating with local, state, and federal agencies, but including your communications plans of how you're going to actually communicate with your staff and your patients, your board, if you have volunteers, your contractors, you use those. I know like a lot of community health centers use maybe dental, that's folks that are contractors, or they might use additional providers. They're providing ophthalmology or mental health or whatever that may be. They should be trained on your emergency procedures as well. This is what we hear from providers. So when we talk to everybody, and they look kind of very similar. If you look from this slide to this slide, not that we went looking, but it was very similar. We had no idea about the plan and training requirements. Like they were completely caught off guard. They gotten surveyed. We've actually gotten calls where we've gotten a call on a Tuesday. They'd gotten had a survey, didn't pass their survey, and said, it was a Tuesday, and they said, can you do our full scale exercise by Saturday? We have to turn in our corrective action plan, so we've had those kinds of conversations with people. And so they just essentially left flat footed about it. Not sure why they didn't have those requirements understood well, but we've gotten those kinds of things. We've also heard it's been hard to find another provider or agency to conduct a community-based exercise with in order to meet that community requirement. That's a great question. And what we have told people, and are really to clarify with people, even though that community-based exercise requirement is no longer, sadly, a requirement, it's still, again, a best practice. What we've told is that CMS did not define what community meant. So it could be you're a skilled nursing facility, it could be another skilled nursing facility, and that's your community. Or it could be emergency medical services, it could be public health, it could be hospital, it could be community health center, it could be a community, it could be a family resource center. You define what community means to you, because likely your community is who you're going to be impacted by, and disaster is going to be different. So that's something we heard a lot. Well, can't anybody get in you to play with do an exercise with us? So we've heard that quite a bit. What I always tell people is to offer to serve in other people's exercises, because they have exercise requirements as well, and you can serve as evaluators. They can serve as evaluators for you. It helps build that relationship in a disaster, in advance of disaster, and that what makes communities more resilient. We have also gotten questions. We passed our survey and they barely looked at our documentation. And what we're hearing from that, and we haven't heard it a lot, but we have heard it enough, is that you have to remember too that the surveyors, this is new. These requirements are not something they're that familiar with. Remember, it's only 2 years, and not, again, every provider has been have been surveyed as of yet. So they are, when they're coming to serve you on a life safety or anything else, they know those requirements backwards and forwards. They may not be as familiar with these requirements. In addition, we've heard we haven't been surveyed yet. When will that happen? Again, it's going to vary by provider type, and it's going to be provided by different states. So that's a good question. And then we also hear the kind of the bemoaning of, do we really need all this stuff? This is really, oh my God, this is overkill kind of thing. And, that's a broader question about disasters. It's obviously, it's something we haven't, we're always top of mind given that what we do. But yes, we do think that you need at least some of these things in order to be better prepared for disaster, because you never quite know what to expect. And then last thing, we just heard this recently from a colleague at Phrenesis, and he was saying that our state surveyors are still going to hold us to the 2017 emergency preparedness rule and not the 2019 requirements. And I was like, wow, that's not one I'd heard before. So I'm interested to hear if your surveyors or your associations or your coalitions are hearing that sort of same thing. I'm not really sure to answer that. The issue is we hadn't heard that. But the point is don't know why they feel the need to do that, but CMS, you should be able to give them some pushback and say, look, the 2019 requirements is what we've met, and we're up to date, and for whatever reason the state has a different viewpoint of that. That might be some advocacy you need to do around that issue. Okay, here's the thing that I bemoan. The elimination of coordination with local, state, and federal tribal. You heard me say this a bunch. So it's it's no longer required, but it's emergency management best practice. So we highly, highly recommend it. Having your local duty officer, your county duty officer phone number and email in your communications plan is just really vital, because they're going to stand up their incident command. So they may not have that stood up 24/7, 365, but I can tell you that phone number, your duty officer, is someone's answering that phone call. It might be 2 in the morning, and that email, but we're based in California, so we actually have wildfires on the brain just because so much of that's happening around the state. But something happens in the middle of the night, they need to be able, you need to let people know, do I have to evacuate, do I have to shelter in place, how do I get resources, those kinds of things. And having those relationships in advance of disaster, really, and it's not just a relationship, hey, I've got their phone number in my back pocket, but also training with them, doing exercises with them, training their staff with with local agencies, and also, do you have memorandums of understanding? It's a great best practice. It's a policy and procedure requirement depending on your provider type. But those MOUs in place really can make a difference. You're not spending time in the midst of disaster to say, here's our resources, and here's where our resource needs are, and this is who we are, and you're handing over your business card. I call that just-in-time relationships, and I'm not a big fan of handing on your business card when you're in the middle of the emergency operations center. You really need to have that in advance of disaster. So sorry to get on my soapbox a little bit about that, but it's just, I think even though I'm just bemoaning the lack of this requirement, but we still recommend, because it's just highly, highly recommended. Okay, we're going to talk a little bit about preparedness compliance and ways to encourage it within your organization. And we're actually, I think we're fine on time. We've got a fair amount of, 20 minutes or so for questions, but we know that by forming a safety team to work on preparedness activities in your organization really does make a difference. And we really think that it's important to do a multidisciplinary team. So your provider, let's say your hospital, you really want to have facilities and clinical representatives and IT and administration, all, and maybe several of your other departments put together with your environmental care committee that develops, and you conduct those regular meetings and you regularly look at your plan. That's a good way to not just encourage preparedness and compliance, but more importantly, you're operationalizing compliance and preparedness in your organization. The other thing we think is a really best practice is to incorporate preparedness into training and exercises throughout your organization and throughout the year. You can do, zombie apocalypse exercises. You're going to talk about coordination. You're going to talk about triage. You might talk about communication and standing up your incident command, or whatever those things are. But kind of thinking about throughout your organization. And then make your preparedness activities doable so that you're, don't say, oh, we're going to do a full-scale exercise 2 a year, and maybe you just started with a tabletop exercise, discussion-based exercise last year. Maybe that's like a bit of biting off more than you can chew. So make it doable so you can reach those goals. Big fan of making an annual plan for emergency preparedness training and exercises. We do a process called MITEP, which many organizations do, which is multi-year training and exercise program plan, and kind of looking at over the next 3 years, what are your overarching goals for every year, and then kind of the training and drills and exercises that you want to have your staff and your community meet in order to meet those goals and exercises, those goals and objectives. Creating a culture of compliance within your organization. You probably have, think and look for those champions, preparedness champions within your organization. It might be a janitor who is a Boy Scout leader who is phenomenal and has preparedness on the brain, or maybe they're ex-military or ex-EMS or whatever, however people got the preparedness bug, or their community emergency response team member on the weekends, or their search and rescue, or whatever they do. Include them into your safety team, include those folks into your, because that will help that culture of compliance and coordination. And then just a reminder that, compliance is a condition of participation. Sometimes that, maybe it's higher with your senior C-suite, senior leadership saying, it's not like it would be really nice if you comply with these requirements. You want to continue to receive Medicare and Medicaid. It's important. So I'm going to talk just really briefly about what compliance surveyors are looking for. These really 2 things. They're looking for that your staff are trained on these compliance requirements. They could grab a random medical assistant or orderly or, a CNA and said, hey, by the way, do you know what your evacuation plan is? Or do you know your shelter-in-place procedures? Because they want to know, because it's really not just, do you have that big binder of documentation? Do you have all the sign-in sheets of all the trainings that you've done and your after-action reports? They're going to see that documentation too, but it's how you've given that staff the muscle memory. So those are the 2 things they're going to be looking for. And going back to the things that they got cited for, is that people, they might have had their documentation, but they weren't training their staff on what those requirements were. Okay, we want to leave you with some planning resources. So we're a big fan of Tracy. Ask for Tracy as Assistant Secretary for Preparedness and Response. They have training. Tracy stands for, I think it's Training Technical Assistance. I forgot what it stands for, but there's great resources. You can actually search. There's a huge database of stuff by provider type, and there's all sorts of like vaccine, how to deal with vaccine controls, and how to deal with power, alternate power, etc. I know many national organizations and other folks have posted their materials as well, that included in their database, and that's searchable. You also can get their newsletter and view their Twitter handle, etc. The top hot link that we included, this was a survey, this is a presentation that CMS and ASPR did last year at the National Healthcare Coalition Conference on what the trends were around survey. So that's a lot of the data that I incorporated into that one slide that's there. I thought it was really helpful on and like exactly how many people who had been surveyed, exactly how many providers by survey by provider type, etc. And then this is the surveyor training. I included that link again from that previous slide. The CMS emergency preparedness updates, this comes directly from CMS. So you can sign up for the links there. And then healthcare coalitions, we've talked about those a little bit, but every state has a healthcare coalition. They're organized differently in every state, but that's the link listing by state, and get emails and participate in those. Oftentimes healthcare coalitions have, it's not They're all organized a little differently, but it's generally CMS providers and EMS and public health all coming together for community response, coordination and training. So big fan of coalitions. So we've got some time. We want to hear about your organization and kind of if you want to share with us either some of your questions or comments or answers you're not getting to your questions from other sources, if you can share with us. We have some questions?
We do.
Okay.
Okay. My understanding is that after November 29th, 2019 is when the 2019 requirements will be required. It's what I've been hearing with our healthcare coalition.
Okay. Yes, that is correct. Yeah. So if you're surveyed between now and November 29th, you will be surveyed based on the previous the previous requirements that we talked about, where you have to have the community coordination and the 2 exercises.
Is collaboration with the healthcare coalition still a requirement?
It is not a requirement, but it's a best practice. Thank you very much for allowing me to say that one more time. I'm sure you're already sick of me hearing saying that, but it's just important. Yeah.
Is it a requirement for a hospice to inform patients of the emerging infections in their area? If so, where can I find that in the regulations?
I don't have the specific regulation in front of me, but I can tell you the emergency and the emerging infectious disease requirement came out in March of this year with the new the Appendix Z. So we have actually included a emerging infectious disease response plan, and we can get you that information. But at this point, yes, it's something you're going to have to monitor and have a way to deal with any kind of infectious disease event.
Do home health agencies have to have a generator?
Home health agencies do not have to have a generator. Those inpatient hospice organizations that have some hospice that are not hospital based, but have a hospice organization, they do have to have a generator because they're inpatient.
I see that a lot of you are raising your hands and have questions. If you could type your questions into the question page, we'll be happy to answer them.
And if we don't get to them all today, we'll do, if there's a number of them, I take it. Teddy?
We are a skilled nursing facility. Do all of the staff need to be trained in the tabletop emergency preparedness exercise?
That's a really good question. So CMS is not, when they're saying do an exercise, there's not like a threshold of how many of your employees have to participate in the exercise itself. It's a best practice to train as many of your staff as possible. And if you have a large organization, maybe you do several tabletop exercises.
If I could chime in on that one, yeah. I think with
Karen, this is Karen. Yeah, Karen Garrison, our Director of Aging Services. Yeah, do you want to share, Karen?
I just would say that, especially residential programs, that it is important that you have all shifts at least. You know, you want to make sure that your night shift is trained because things happen in the middle of the night. So it's very easy to just train your days, you know, your staff on your first on working days. But as you kind of go up, you know, and get to those night shifts, having an effective training for those staff, not only are they trained, but they're actually, as they rotate through other shifts, they'll know what to do. And so it's a great best practice to really look at staffing and training from a holistic perspective, because a third of your, you know, many of your staff are working days, but you're working with a smaller staff in the middle of the night. And so there's more for them to do during an emergency as well.
Another question is, do you need to train new hires within a certain time period?
Another good question. What they're looking for is you probably have a new hire orientation. CMS is not saying you have to train them within 30 days on staff, etc. The intent on initially, what they're saying initially, right when they start, you're going to do it, that you incorporate your emergency preparedness plan into whatever your new hire orientation is and document that they were trained on those procedures.
Another one is about ICFs. One of them is, are we required to have a generator?
You're an inpatient provider, so yes, you are. And there's updated requirements on the generator and what means alternate power and what exactly it has to cover and such. That's clarified in the rule, which we're still determining what more detail on that.
If you want,
yeah.
If I could just say something, if you actually want very specific information, just Google Appendix Z under CMS, and they have a huge amount of information in there. So it's about a 75-page document, but it actually lays out each requirement for each provider type. So that's a really great resource for you to just have on your computer so you can kind of glance at it as you need.
Right.
Another one about an inpatient is, are there requirements for what to have in an emergency kit? They got hit on for not having sleeping bags and mobile water.
Oh, really? Okay. So again, that's sort of the variance from surveyor to surveyor, is that they're saying have emergency supplies, but it's not that specific about, it's not usually to that level of detail. It could be that that particular surveyor had wanted to make sure that that was had. That's surprising that they gave you a deficiency for that. Other questions?
Yeah. Are outpatient surgical suites in a hospital subject to the same requirements of that hospital? Or is it something different?
Are they okay.
Outpatient surgical suite in a hospital.
In a hospital. Are they still have to meet the same requirements that the hospital does?
Mm-hmm.
Yeah. Generally, there's an option called an integrated health system requirement, so that generally, if, for example, your hospital has skilled nursing and ambulatory surgical centers or private, you can ask the surveyor, you will, for an integrate, you can, pardon me, the ability, you have the ability to say our plan covers the hospital, but also the other provider types within our hospital system.
Somebody would like you to review the term functional in regards to the testing.
Very good question. Okay, so there are 3 different types of operations-based exercises under the that's done forgive me, sorry. So in Homeland Security exercise and evaluation, although this is not required, there is a definition of a functional exercise. Generally, a drill is your only drilling, and that's a operations-based exercise. You're only drilling one single function like evacuation or communications or standing up your incident command. So that's only functional. You're only testing one piece of your plan. When you have a functional exercise, you tend to test more of your plan. You might, at the same time, you do an evacuation and you're testing that operations piece of your plan. You can also test your communications, and you can test, let's say, standing up your incident command, EOC, Emergency Operations Center. So functional exercise tends to mean that you test more pieces of your plan than rather than just that one single thing, such as a drill. When you're talking about full-scale exercise under the definition of Homeland, with HC for Homeland Security Exercise and Evaluation program, generally you're saying full scale is you're testing all the pieces of your plan as much as possible, and you're testing that with other agencies, and it's multi-agency, et cetera. Again, we got clarification from CMS. They did not mean that you had to have, again, multi-agencies and, blowing stuff up, et cetera. Again, they just want you to test more of your plan, more of your exercise. So when they're saying functional exercise, they would like you to, so you can do just a drill, You can do a functional exercise, which is you want to test more of that, which is we recommend, because the more of the plan that you test, the more findings you have. And the whole point of the exercise is not to just do an exercise and write an after action report. The whole point of that is to find the plan gaps. So we like to say, we want you to fail spectacularly during the drill, but actually not during the disaster.
One person wants you to clarify HC.
Sure. Homeland Security Exercise and Evaluation is a program that was developed by FEMA, Homeland, which is Federal Emergency Management Agency. When CMS, when exercise planners like us hear full-scale exercise, we normally go to the thought process of a full-scale exercise with you know, again, lights and sirens, etc. And HC is a program, it's really, and what you can look at it as a guide, not a Bible, of how to conduct exercises. It's a good best practice, and it's something, again, it's a best practice, and something that we use in our plans and the toolkit, which I'm going to talk to you about, some of those things that are really helpful. So Homeland Security Exercise and Evaluation is what HC is.
Are organizations obligated to use FEMA documentation forms, or are they free to use their own organization standard or new documents?
Really good question. So CMS does not have a preference for any kind of form. So for example, that's why they're not requiring you to use HDEEP standards and et cetera. What they most care about is you got them completed. There's not only one way to do a hazard vulnerability analysis, only one way to do a training and exercise. So you use whatever forms works best for your organization.
Another one is the Great Shakeout exercise. Will that satisfy the functional exercise for the year?
If you conducted a functional exercise, if you participated in our presentation, and no, that won't count. You actually have to functionally do the drill itself and then write the after action report to document it.
Okay. This one's a little bit long, so forgive me if I stumble. While the update eliminates the requirement that the emergency plan to include documentation of efforts to contact local, tribal, regional, state, and federal emergency preparedness officials and a facility's participation in collaborative and cooperative planning efforts, and he agrees that it's a best practice.
Right.
There might be expectations from healthcare coalitions, county public health, et cetera, to participate. Do you have any thoughts or experience with this?
I guess I rely back on, we think it's a best practice. So they can't require you, if you're participating in the coalition, that you have to come to every exercise and participate in every exercise. I don't think that necessarily that will happen, but we know that you're better off for doing so, because one, not only that you participate in the exercise, but you know each other in advance of disaster. So we think that that's important. Okay, so I just want to briefly kind of tell you also how we can help you. I know we're running out of time here. We actually have a compliance toolkit that we've developed. Some of you on the call might have already purchased this, or we've worked with you, and we've used this toolkit for your organization. So it is everything you need to be compliant. So I have to say that this was written, we've been kind of innovating over, this is probably version 2.0. So it's got an emergency preparedness program plan, site-specific annexes and appendices, hazard response guides for active shooter, workplace violence, flood, tornado, etc. Incident command system documents. It's based on best practices, and also all the sample policies and procedures. You actually can purchase the toolkit for just $500, and you get 2 hours of consulting for free. If you do that by December 31st, you actually will get the 2020 version that we're going to actually put out, because we've been working on this for a while, and then the rule change happened, so we have to update our version as well. But if you wait to purchase, it's going to be $800 plus 2 hours of consulting. So we want to make sure that you get that, have that offer available to you. I do want to let you know a little bit of what we're going to be doing for 2020's toolkit. So it's going to reflect all the changes for the Omnibus Burden Reduction. We're also going to streamline. We're always in the process of updating, but we want to streamline and offer a more user-friendly toolkit layout to make it easier for you. We're also going to, it now makes sense to do a very detailed provider reference chart for all the changes related to the frequency of plan review and updates and drills. And a lot of these questions you asked on today's call, we're in today's webinar, where we're going to answer in that reference document. And it's going to be, we're going to have this reference document for all 17 provider types. So you'll see when you have to review your plans and when you have to, and the types of drills you have to do, et cetera. We're also going to update because of the training, drill, and exercise changes. We're going to be updating those resources, and this will be available to you in early 2020. And again, if you purchase by the 2019 version by December 31st, and you can get it for free. One other thing too, going back to this link here, this is a direct download. So you go to go to the link, pay for it, and you can download it and then schedule your hours of consulting because we're here to help. You want some more information? We have webinars every month. You can link and join our newsletter. If you just want to have questions, you can book a call with us at that link and say, I have some questions about how to do this and how do I do this? You can just see our availability and book some time directly from that link. And thank you so much for joining us today. We really do appreciate it. Those questions that we didn't get to answer, we're going to pull those out. We'll create a frequently asked questions, and that will finish the answers to those things and get them back to you. But reach out to us and see if there's anything we can do to support you. Here's my contact information, and we look forward to continuing working with you.
Please follow us on social media and follow our YouTube channel. If we get to 100 subscribers, we can name it. In the email that we send out later today, we'll give you the link to our YouTube channel. This is where all of the past and little snippets of videos and stuff like that will be posted. So if you've missed any of our webinars in the past, you can watch them here, plus other CMS emergency preparedness content.
Yes. And Karen, thanks also for joining us today, and I'm happy to see you. Yes, thank you so much.
Mm-hmm. Right. Have a great day, everybody.
In your email, you will receive a certificate of participation.
Thank you.
Thank you.